All right, it's time for us to take on the issues for the day, but let me first of all welcome Chamberlain. First of all, what's your own experience coming to work this morning?
Yeah, I mean, we'll have to stop by and just do a couple of checks on the roads. Yes, people have gone back to the roads. The state government did say that people were required to put on their face masks in public while they are there. So they have to get used to it.
Yeah.
And sometimes you see one person in the car with a face mask. Nothing wrong with that. It's just getting used to that they have to. So it's something that, if not the country, will eventually have to get used to, because there's a lot of uncertainty out there now. Absolutely. Because we don't know how this is going to. But yes, we've seen the stats of some of the countries who did a similar thing, such as ours, and we saw the results. So many are waiting, perhaps with bated breath now, to see, oh dear, how will this eventually pan out? And then there are those who, well, first, as a result of the directives, they have to be at home in states that this lockdown has happened. But then you have others who say, I think I'll wait this out for a while and see what happens before they eventually hit the road. So the roads this morning, not as heavy as they usually would be. I mean, Third Mainland Bridge, same thing. But we will check a little later, hopefully, with some other areas and see how those roads reflect today, where we're easing the lockdown amid pandemic uncertainty. But you also do remember the state government did give some directives, much as the PTF COVID-19 equally did give some of those directives. But then how all of this will pan out will be what we will keep our tabs on. So this morning we've got Dr. Patrick Dakun. He is the CEO, Institute of Human Virology. Good morning, Doctor. Good to see you again. Good morning, Nigerians as well. Well, Doctor, this is
good morning,
one of those uncharted territories.
All of you out there.
Yeah, one of those uncharted territories. What do you see happening now that some states have eased this lockdown, Lagos inclusive?
Well, first of all, I think as a country, and especially for individual states, it's walking a very tightrope. Walking the tightrope between the economic reality in which we find ourselves and also the public health reality that we find ourselves. No country has ever found this easy. And everybody is moving in, you have rightly referred to it as very uncharted waters. And I think what some countries have done is to do what I have referred to as break and quench, you know, the old vehicle that, you know, will move and stop. And in graduated format with the days that people are allowed to go out much shorter than the days that they are locked down, with the hope that they can combine the need for the economy and for the public health at the same time. What I foresee in Nigeria happening is no different from what we have seen in other countries. Look at Ghana over here. And if we go right back to the Spanish flu in 1918, 1920, the same thing happened. When people were allowed, when the lockdown was lifted, after a couple of weeks, we found a very huge rebound. And in the Spanish flu of 1918, where a quarter of the whole world, you know, passed on, it resulted again in another lockdown that lasted longer. So in Nigeria, I also expect that the easing of the lockdown is definitely going to result into another rebound. How big that rebound is will depend on a couple of things. Number one is the level to which we can aggressively find out those who are positive in the community, isolate them and treat them and place them on treatment and pursue their contacts. The more aggressive we can do that, the less the rebound is going to be. But as to whether a rebound will happen, it will definitely be. I think that the ball is now in the court of both the officials that are responsible for carrying out community testing and the community itself. Chamberlain, you are giving an example of yourself coming through the road, and I'm not sure whether the percentage of people you saw wearing masks. But for me, here in Abuja, leaving my house and coming here, it's a pretty short drive, maybe just about 17 minutes. But what I have noticed is the fact that I can say close to 70% of the people I saw on the road were not wearing any face covering. And remember that face covering is your expression of love for another person. If you think that you care about me, then you wear a mask. If I think I care about you, then I wear a mask. So I think that we are going to be seeing a very challenging time in terms of enforcement of the rules, since people may not necessarily be arrested because they didn't wear a mask. But at the same time, again, on the public health side, we must be very, very prepared.
It's interesting when you say your face mask is your expression of love for the other person. I think I would like that to hit home for a lot of people, because once you begin to see it that way, well, except you don't love the other person, but once people see it that way, it might make more sense to them. But, you know, speaking about enforcement, because it seems this is going to be a big deal, do you think that the government should really enforce this, or they should rely on people, I mean, moral suasion maybe, to just fall in line?
I think it should be like what I heard the Presidential Task Force chair mention at one point in time. He said that somebody has come out of the road, you are an enforcement officer, rather than clamp on this guy and begin to beat the guy up, why don't you just talk to him in a gentle way and say, hey, look, you are not supposed to be on the road, I'm not going to let you pass, so please go back. If he insists, then you can begin to enforce the law by arrest. I think for face masks, it should be a combination of an appeal and also some level of getting people to know that there is a consequence. An appeal in the sense that if we appeal to people for them to see reason for why they are doing what they are doing, it probably will enable us to succeed better. A law that people identify with and they think that, yes, this is for my benefit, is a law that they may really obey. For example, we talk about it in the context of love, but we also talk about it in the context of your responsibility to society. Do you have a responsibility to your community, to the people that you pass by? If you have a responsibility to them, then you go ahead and put on a mask. But if you think you don't, then the community itself may begin to take action on you. I can see a situation where it's a choice. You want to wear a face mask, or you want to catch a disease, or do you want a face mask, or do we take you and quarantine you? Because if you are not, then you are a candidate to be isolated, because it means then that you pose a risk to society. So I think it's a carrot and stick, as we call it, for people. Community leaders that will live by example, community leaders that will also, just talk to their people at various levels. I think we will achieve a level of success. We have got, Nigerians are structured in some form of way. You either belong to a church, a mosque, or you belong to a market association or a resident association. All these, groups, we should utilize them as much as possible for driving home this need. Because as for wearing of mask, I think we should be prepared for a very long distance race. It's not going to be a short distance race. So people must be prepared that this is going to be the new norm. And typical Nigerians, I'm sure you have seen it all over. There is Ashwebi now with mask attached to it. There are even Gucci kind of face masks. So we are coming up with cool ways of making it look appealing so that people don't see that it is, a barrier to their fashion.
I see you also have your face mask right there. But, there are those who feel that this is premature. In fact, groups, individuals, political parties think that this is too early. But the question is there anything as a perfect time to ease this lockdown?
It's early, or is it the face mask that is early?
No, the easing of the lockdown. Is there anything as a perfect time to ease this lockdown?
From a public health perspective, we say the easiest time or the best timing is when the curve of the epidemic is going down. When you flatten the curve, meaning the new infections are not coming at a higher increasing rate every single day or every single week, depending on how you are measuring it, and that it has begun to go down, it has started going down. So you use that as an indicator for gradual easing down. But in Nigeria, we had not gotten to that stage where we had flattened the curve. And for some of us, we felt that, look, maybe we should have added another 2 weeks. But if you look at the implementation of it, it's difficult again to see the necessity for a total lockdown when enforcing that total lockdown is extremely difficult. People who say it is early, I will request that they also give the suggestion as to what to do with the economic indices that we're seeing and with also the stress that people are going through. You see, the situation, if you are living in a very cozy, rosy place, you may not realize it. But no matter where you live, I go out from my little place to walk around in the evening just by neighborhood, do some little exercise. And by the time I'm coming back to my house, now it's a routine that there are people around in the neighborhoods that live in batches not far away that will come up to tell me that, oh, the supply of food that you assisted us with has run out. We don't know what to do. And I say, okay, why don't we do it this way? You get this, go and get. And I'm asking myself, for how long will this continue? And for how long will my own supply last? So definitely some easing is absolutely needed. But what to do while that easing is taking place is the issue that we should be focusing on. Now that the easing has already taken place, let us go ahead and see how far we can implement everybody's loving each other by wearing a mask and by social distancing. And if you are going to enter my office now, if you are a visitor, you probably will not enter to see me because we will talk on phone. We have an intercom. You will talk to me from there. Unless it's necessary for me to see your face, you won't come as a visitor. And even my staff, within the context of the office, if they are leaving their desk, they will put on a mask because I don't know where each person is coming from. And then the social distancing, we are now staggering it. If in the office space you cannot maintain a 6-feet distance where you sit, then you alternate days. So we have one half of my staff coming today, the other half will come tomorrow. That's how we alternate. So this will continue for a while until we see the cases coming down. And you clearly see that we're still on the upward rise. And where we never thought that we will find very huge problem, now it is. Kano is now number 3. So it's number 2 now in terms of number of cases. So we got a lot of work to do, and I think the responsibility lies with both individuals, community leaders, and also with the capacity to be able to ramp up testing. The target for 2 million is quite gigantic. I'm not too sure we are going to be able to do that. But I think that my advice, some of my staff also work on that side, is strengthen our logistics system, so that we are able to determine the needs of every lab in terms of reagents at each point in time, recalibrate. We've done it in the HIV community, and therefore it's possible that if, for example, we do not have the adequate quantity of either reagents or test kits, we recalibrate. Where the testing number is not as high as needed, we redistribute. But somebody that is an expert on logistics needs to also be on the team and give some technical support.
But one of the things that you have said so far, is that we are in this for the long haul, and that's what many people also understand. But there are also nations. Well, the example of Ghana that you cited, and of course a number of other countries, even the Spanish flu that you referenced. All these are facts. It's also a fact that in some other climes in this world, concerning this COVID-19 case, there are nations that have reopened and there hasn't been a surge. There's been no surge to return them to a lockdown. And from what you have said, it seems that we are likely to go back into this lockdown if we do not take certain measures. Is there anything we can do as a people and as a government to avert going back into a lockdown as a result of a spike occasioned by this return to work?
So let's go to the countries that have, eased out and have not gone back into lockdown. Let's use the example of one that I read just 2-3 days ago, and that's Taiwan. And the aggressiveness of wearing a face mask was such that You know, in fact, some folks there were asking whether their pets too should wear should wear a mask. Of course, that was not needed. But that's to tell you the extent to which the information about the need and the compliance of wearing a face mask had gone. So for us not to go back to a lockdown, you know, a total lockdown, we need as a people to ensure that nobody that gets out, steps out of his house, he has his face open, wears a face mask. We need to aggressively ensure that, you know, community-based testing is going on. Look, and we have examples. We don't need to go far in how to ensure that we do that. There is a mapping that needs to be, that we currently are doing. And that mapping is to say, if we come to Abuja or to FCT, must we go and test everybody in FCT, or can we now begin to narrow it to epicenters? And once we are done with mapping it out, we can put in all the resources that we have in the places where we have a lot of concentrated cases, while ensuring that we do not totally leave out the other areas that don't seem to have a case, because maybe it's because they are not testing that they are not seeing it. So summary is test as much as you can, using whatever strategies you are to maximize the resource that you have, and then wear your face mask, social distancing. And talking about the testing, people have said, well, 18 laboratories, in what way will that be adequate? And I think that, yes, we can add the number of testing sites, and there's quite a lot of work going on there in ensuring that we have additional testing sites, at least in every state. But I think the logistics of sample collection is very, very key in utilizing and maximizing the use of even the available labs, because sometimes you hear statements like, we have not even maximized the use of the current labs that we have. We have X number of labs with X capacity, but they are underutilized. Well, they are underutilized because samples are not coming. Samples are not coming because the logistics for sample transfer has not been adequately arranged. My advice has ever been, for weeks now, that every primary healthcare center in Nigeria should have the capacity to be able to collect samples, store the samples, take the samples to, even if it is taking it first to a staging area, and then from the staging area to the lab. And then the turnaround time, if we can make it a minimum of 24, a maximum of 24 hours, 48 hours maximum, then we will be able to get results back early enough for those who are positive to know their fate. Because if you are doing a community testing, you go there, you test, you don't tell everybody, you advise them on personal hygiene, you advise them on ensuring that they maintain social distancing and wearing of masks if they have a cough. But you probably, because they have not tested positive and they have not been exposed to a case, you are not strictly isolating them. But if they get the test early, it reduces the exposure to others. So,
speaking about, whether or not we understand this a little more to help us in terms of how we conduct ourselves now that some states are easing the lockdown. Now, and if I could follow up on some of the points you made, some have given the example of South Korea, where they think that the fact that they were able to just let the people know, well, this is one of the areas that this person has tested positive, so just be careful in those areas. That, they think, helped them a lot. Is it something you think we should consider to help? Because I know Lagos did something similar to that. Should we nationalize that kind of scenario such that people can indeed, perhaps when they know certain areas, they may conduct themselves a little better? Will it work?
Absolutely. It is, for me, I think it is very important, because we are not divulging the personal information of any individual. Therefore, we have actually not contravened any, what in medicine we call the HIPAA rules, that is confidentiality for individuals. So it means then that if I now tell you that, no, let me even give a practical example. When we were talking with some folks and they said, we are not sure whether this thing is even in our place. You know, one of the people that was living with me, he comes in and goes, does some little work. And I told him that, have you heard that they have found some cases in the area you are staying? He said, is that true? Which area? I said, the area you are staying here in Abuja, they have found some cases there. Do you know that he was asking me, is there a place he can stay there? He doesn't want to go back to that place because he now sees the thing driving home. If, for example, in FCT, we now say, Mabushi, you have a high rate. Therefore, people there in Mabushi take an extraordinary care. I am telling you, only somebody who, that in colloquial English say, get sense. That's why he could do like that. If somebody does not want to think, then he will not take care. So knowing the epicenters within a geographic area, making it public, will enable the people there to see the reality of the fact that the disease is not a theory, it's not a fake news, and two, that it can catch you. Then I also love the what we are beginning to see some people do now, that patients themselves who have recovered are on their own coming up to the media and now giving their experience. And when people see and hear them, they begin to know that, oh, one, it means I can get the disease, but two, it means I can recover. It's not necessarily a death sentence, because what is the big fear factor is the fact that the mortality is what we are pronouncing. Oh, so recovered. Yes, it's good. But who is it that recovered? When they see those kind of stories, I think the people will comply better.
The other thing about this is that, yes, this is a global thing, and we're trying to learn as much as possible. So different regions look to other regions to see what can they learn differently. But over the weekend, I heard some articles, read and heard some referring to it as saying the strain that you have globally has mutated. For instance, they think in our climate, you could have the S or the L strain. And as such, you may not have the same kind of impact you're having in some of those countries in terms of the death there. Does that make any sense?
Well, I've not seen the report of the genetic, the strain that you're talking about. I've not seen it. All I know is that we have the SARS-CoV-2 virus, the particular subtype, or whether it has mutated, I'm not too sure. However, we do know also that from a public health perspective, that the virus is not behaving in the same way everywhere. For example, we do not see the level of infectivity that we see in some other countries. Could it be as a result of environment? We don't know. Could it be as a result of our population age, that is the pyramid of our population being skewed more to younger age? We don't know. But these are things that we will need to be figuring out. And in terms of the mortality, however, case fatality, we can clearly see that our case fatality is no different from most other countries that we have seen. People have said that, oh, it's just the elderly that are affected. But recently, Lagos, I think, reported a case of a 25-year-old. And we have also got reports of infants that have been infected with the virus. So what is it about us that is different? The good news is the fact that we are not just sleeping. The NCDC, along the Presidential Task Force through the NCDC, has got a research consortium made up of technical partners. My institute is part of that, that consortium. And our goal is to take up all the ideas that people are bringing from the different science community, put it together and see what ideas make sense and see how those ideas can be pushed forward. And we are hoping that if adequate funding is available for such, then we'll begin to get answers. But at the same time, also, we are beginning to get information as we go. We call it implementation science research.
Okay, Doctor, what we'll do is we'll still have some grounds to cover. Perhaps we'll let you continue on that point when we return in just a moment. Stay with us. All right, welcome back. Dr. Dakum, you were going to make a point about some of the data, information that you've been receiving. Could you go ahead, please?
Yeah, I was making a reference to the fact that if we look at the data that we have now related to what is different between what we are seeing here and other countries. We can clearly see that, first of all, our case fatality rate is no different from what it is in other countries. For example, we've got 80-something deaths now out of a total of 2,700, 2,800. I don't have the figure off my head now, you know. But it's roving usually between 2.5, 3.5%. There are countries that have gone up to 5%, some up to 10% in terms of case fatality, meaning out of those who have the disease, the number that have died. So in that context, our case fatality is not different. In terms of the total number, we probably may be too early to conclude on that because our testing numbers are still low compared to the testing numbers that we see in other countries. So probably by the time that we see this totality in terms of now we are having 1 million tests that have been done from the current less than 20,000, and then we see the number of cases, we'll be able to say whether this virus is behaving completely different here than it is in other places. But for now, I think the modalities for prevention is not different than we find in other countries, and we must live with that.
I know there's been suggestions that Nigeria should go the way of Ghana and adopt, that lumping up together of tests that Ghana, employs to test more people. But, I'd like to go back to the conversation about whether or not this is too early or not. I recall that for Lagos, when this started, the Commissioner for Health gave a worst-case scenario, saying that, we might record about 40,000 cases, but we didn't record as much. And maybe that tactic helped such a way that people shaped up. You recall for Germany also, the Chancellor saying that, we might record 70% of the population getting infected, but they've recorded over 165,000 compared to about the 58 million they would have recorded. So do you have a worst case scenario, or is there a concern that we don't even have a worst case scenario for this, gradual easing, such that people don't know how bad it could get, so maybe it cannot hit home for them?
I think to put it in a very direct way, I think we stand the risk of having close to about, will I say, 5 to 10% of the entire population having this disease. If you look at the data that the Commissioner for Health, Lagos State, shared one time about their community testing, he did say that they go into the community. Those that have got respiratory illnesses, that is cough, catarrh, anything, those are the set of people that they test. Of those that they tested, 20 to 25% of those people have tested positive for the coronavirus. So let's extrapolate then. In the general population, how many people have respiratory illnesses? We probably could say that at any point in time, close to about 5–10% may have a respiratory illness. So if you take 10% of our population of 200 million, that's 20 million. So assuming out of that, we now calculate to say between 20 to 25% of them will test positive for the coronavirus if we don't do anything. Well, 20 million, 10% of 20 million is what? Is 2 million. Well, 20% is 4 million. If we're not careful, we may have between 2 to 4 million people that may test positive. And assuming only of those who test positive, 5% of them are critical. 10% of about 4 million will be 400,000. Can you imagine us having about close to about 200,000 people needed to be on admission in hospitals in this country? That would be terrible. It means then that you can never be sure. And remember that this thing is exponential. That is, you catch it, you are potentially infective to several other people. His Excellency, the Governor of Kaduna State, Nasir El-Rufai, did say that I infected 4 people. Well, the number of people that are exposed may be probably more than that. But the ones that have confirmed test positive is 4. So for every case that we are talking about a minimum from his own experience, if we are to use that individual data, which of course statistically we cannot, but at least that's what we have to go by publicly that he stated. Then it is going to be terrible. Here in FCT, it means that by the time that we have we do nothing, we probably may end up with close to about 5,000 to 10,000 people needing admission. Where are we going to put them?
Dr. Akum, there's something that came to my mind over the weekend, ruminating on this. Well, we have been told by, you and your colleagues in the medical profession that the recovery rate, so to speak, of COVID-19 is in the region of 10 days or thereabout after the person has been confirmed. Those who will recover maybe about 10 days plus or minus. But what we have on our hands now, I'm a little concerned about the recovery rate because the number of people discharged as at the last report we got is 400. The total number of confirmed cases is 2,558, putting the number of active cases in the region of maybe 2,000 or a little less than that over the nation. Is there something we do not know about the coronavirus disease that is making it, slowing down the rate of recovery? Because if it is just 10 days or thereabout that people should recover, don't you think we should have a lot more people to have recovered from this illness, more than the 487 concluded outcomes that we already have?
It may be a little bit early to confirm as to what the average recovery time is. But what I can say is that so many factors could be responsible in you discharging a patient. The patient may look well and may be doing okay, and you will probably not discharge him until you get the result of his test. What's the turnaround time for the results coming back to people that are on admission? I really don't know. I've not seen the data on that, so it's difficult to comment. If, for example, you have one test negative, you've got to have a second one negative before you are confirmed to be negative and discharged. Could it be that maybe the turnaround time for the results is a little bit longer and therefore we see longer delays in declaring people fit to go back? Or could it be some other factors that we have not yet found out? I think by the time that we go through this uncharted waters for a while, looking at the data very, very strictly as we move on and comparing it with what is happening in the other parts of the country. That is, if we pull the data together, then we'll be able to now say this is the pattern we're seeing. But for now, it may be difficult to conclude on saying there are factors that are making recovery longer in Nigeria than it is in other countries.
As people return to work, as a virologist, please tell us, is there certain characteristics of this particular virus or viruses generally that people need to pay attention to protect themselves and the people that they love?
I think if there's anything to say in a layman's language is that the infectivity rate of this virus is very high, meaning that its ability to be able to get into you and multiply and cause disease is much higher than what we see in other viruses. And also, because its infectivity is very high and there is, a 5% chance of getting to a critical situation, it means then that you've got to take it very serious. When last did we have a situation whereby you've got to wipe surfaces, you've got to clean everywhere. I got into a place and they were wiping the POS machine, where they collected my card and then they wiped it with alcohol wipes, It's an indication that this thing is highly infectious, and if there's anything that we need to know as a community, we need to just understand that it's highly infectious. You can get it easily. You can just get it easily. Now, even the 6 feet they are talking about, there are studies that are beginning to show that 6 feet difference may not really give you the protection that you think, because from an microengineering point of view, it looks like droplets can travel faster or further before settling down than the 6 feet. And because they've seen people get infected like that, and now you see so many people. How did this person get the COVID-19 disease? I don't know. They don't know. It means that it's so infectious that they didn't even realize they were near somebody. Maybe the person is asymptomatic, but they didn't realize that there was any risk in the place that they went to. And then here they are with the disease. So please and please, ensure that, one, you cover your cough to protect other people and to express your love for other people. Number two, touching surfaces anywhere you go, make sure that if by any reason you touch a surface, don't assume that, nobody came here, so what's the big deal? No. Even standing near people, look, do you know choristers? A cohort somewhere in the US, these are people that are singing in the choir, but they are singing saying that, oh, everybody is fine here. But almost 15%, I think, of those choristers caught the virus just from their breath alone. So everybody has got what is called a breath cloud around him, and people staying in the same breath cloud with you can infect you. And that is why, because of that, we need to be extra, extra cautious.
Well, Doctor, I mean, listen to some of these things, you just wonder, oh dear, is there an escaping of this? Goodness, you just wonder, what does one have to do? But then I think it's also equally important that people understand a lot more of this so that they know how to conduct themselves better, so people don't think that they are weird. And nothing wrong in being weird if you have to protect yourself and protect the next person, from catching any of this. But then, there's some reports too. I mean, there's several reports everywhere. Sometimes you just wonder which one to take and how to take them, if at all you have to. Is there any connection? For instance, some say that those who have got malaria, recovered from malaria, have got better chances of survival of this, particularly if they happen to be in the West. Does that theory make sense to you?
Well, I don't think we have any scientific proof that we have a cross immunity, because you have got, you are immune from certain infectious diseases. You probably may be immune or have some level of protection. But there are people that have also come up to say that the reason why we are not getting as many cases as the other countries are, because if you look at the rise in our state, the rise in the number of cases is not as huge as what we've seen in other countries. But I always say we need to be very cautious. Cautious in the sense that if we are not testing as much as they are testing, let's not conclude that our cases are not as high as theirs. But having said that, they have also said that the reason why this is less is because we were exposed to all kinds of pathogens here. And because of all that pathogens that we've been exposed to, our body is stronger in some way to be able to confront disease. It is possible, but it is something that needs to be scientifically investigated, and then to be sure that this is so. And even if it is so, it will not explain the fact that we have cases, and those cases are currently rising. So it will not make us bring our guard down to say, I grew up in the village, we were exposed to so many things, this thing will not catch me. No, no, no. We have seen people that are in every socioeconomic strata that are coming down with coronavirus now. So it means we've got to be very careful. There are other people too that I read a report about a woman somewhere in the US that is worried that children that are born in this sterile environment that we are creating may find it extremely difficult to fight disease in the future, meaning that everywhere is clean, everywhere is mopped up, you don't have bacteria, we are just making everywhere sterile. You go to the house, you find mom is now just mopping everywhere, you find people mopping the steering wheel of their cars, everywhere is sterile. So babies that are born there, will they develop the kind of immunity that we see other children that grew up in all these difficult situations have? But, we cannot say that let us now relax, allow some infection so that we will have immunity for those that are born. No. we will still go ahead because we do know that for the diseases that they're exposed to, we can vaccinate, provide them with vaccinations and protect them from what is common.
But you know, Doctor, there's been several reports about certain persons who are suspected to have contracted the virus at home, treating themselves, not wanting to get to the isolation centers. But the thing is, if you take a look at the community case definitions for the COVID-19 as revised by the NCDC, now some of these symptoms where they classified as suspected cases, they did highlight shivering or shaking, body pains, headache, sore throat, recent loss of taste or smell, difficulty in breathing, shortness of breath. Then they've added diarrhea, abdominal pain, runny nose, fatigue. Now, those who have some of these symptoms will just think, look, this is malaria. These are symptoms that I've treated before, and this is malaria. Why should I think this is COVID? So in this regard, when people have this, what challenges do we face? Because if they think, this is what I've had before as malaria, but now it's classified as suspected case, how should we conduct, how should we handle ourselves, or how should such people respond to this? Because if you have to go with these symptoms, you will have so many people who think that it's just malaria, but it's a suspected case of COVID.
So I think it's very important for the public, for each and every one of us to know that when we say fever, we're talking of a rise in temperature. It can be caused by so many things. In fact, infectious and non-infectious diseases all can give you a rise in fever. So fever in itself as a symptom is not, fever is not equal to malaria. Malaria is not equal to fever. Okay, so fever and the chills and whatever you get, even though they are typical of malaria in our society, they can also be symptoms of other diseases. Because malaria was so endemic, we are so used to seeing, we are used to treating it that everybody treated malaria symptomatically, and nobody even wanted to go ahead and do any test for malaria before taking some anti-malaria. But I think it's important for us to note that the fact that you have this does not mean that it is malaria. It could be COVID. So here comes another disease that has symptoms that are similar to malaria, but not necessarily malaria. So it is new. It has come in. We need to know that fever can also be equal to coronavirus. Fever can be equal to malaria. Or the fact that corona has come does not mean malaria has gone. So it means then that we've got to just, with these symptoms that have been outlined, avail ourselves of a test, call the number that have been provided so that they come and take samples and then test to be sure that this is not corona. Most often they will now conclude and tell you that, oh no, this is not a coronavirus, so go ahead, this is malaria, treat it. Even when we provided, very easy tests for malaria, for rapid tests for malaria, people still were finding it very difficult to test. No, this is malaria, we know it. People with cough and catarrh is clearly an upper respiratory tract infection. They will not, they'll say, no, I have malaria plus cough. So malaria was being interpreted as every fever was malaria, but it is not so.
Well,
so
scientifically, pardon me, I just want to add this, since you've come to that area. Now, this might be controversial, but what is the percentage of error in testing for COVID-19? What I mean is there a possibility that someone might have malaria, for example, and the test comes out saying that this person has COVID-19? Is there a percentage of error? Because there's been controversies, people saying, I don't have COVID-19, don't tell me I have it. So is there any provision for that?
Well, no test is 100%. That is one thing to say. The sensitivity of the current tests that are being used is still something that they are trying to improve on, having an algorithm that will improve on the sensitivity, so that when they say that this is COVID-19, it is actually COVID-19. Some of the tests range in the region of 70, 80%. Some range in the area of close to 90%. I don't know the exact percentages, but none is 100%. And that's why sometimes it's better after a test is done that it is repeated after some time. But at least that it has tested positive requires an isolation. Then when it is tested again and it is testing positive, then you know that indeed this is a confirmatory test. If you look at how we started out with HIV, we never initially used to have only one test done. We will have one test done, then we have a confirmatory test done. And that was because the sensitivity, specificity were not as high as we would want it to be. And we didn't want to label somebody for a lifelong treatment of an illness that he probably doesn't have. So yes, it is true that it's not 100%, but it is indicative of the fact that there is something going on that needs to be looked further.
Now, talking about the community case definitions that the NCDC released on May the 3rd, you see that, yeah, there's suspected cases, and then there's an area for probable case. And he says that a probable case of COVID-19 is any person that presented with any of the above symptoms, which Chamberlain read earlier, in the last 2 weeks and died without a confirmatory COVID-19 test. And, you know, maybe this widens the spectrum. We saw that the deaths spiked from 55 last week to 87 as of today. So that's an increase of about 32. So what does this say for maybe the case of Kano and, you know, some other areas where we had some of these mysterious deaths?
Sometimes it's difficult, especially in situations where the tradition, permit for immediate burial of loved ones. And when you go also to take interviews of people that have lost loved ones, sometimes they are not in the mental framework to be able to provide you with information. However, I think that in the era that we are, and seeing the fact that we have something that we know can be a causative agent, I would assume every mysterious death is COVID-19 until proven otherwise. People have suggested that you can take swabs if the burial has not taken place, take swabs immediately before the burial. Where that is feasible is okay, but where you can just go on looking at the symptoms from what the relations tell you, then you go ahead and make your presumptive diagnosis that way. But I think that majority of the mysterious deaths that we are currently seeing, especially where we know that coronavirus disease is on the rise, is most likely COVID.
Now, one of the things that's giving me concern over time is the reasons for the way people contract this COVID-19. We have had, one of them is travel history and all of that, contact with infected persons. But there is one that's giving me concern over time, and that is the one they call, initially it was unknown sources, now it's no epidemiological link, and it's the highest on that list of 4. Does that give you concern? And what should people do to be wary of that kind of cause?
Well, no epidemiological link will be that we are unable to track you to somebody who is exposed or somebody who is exposed to somebody who is exposed. And therefore, we cannot clearly say that here is where it is coming from. We probably may be able to get to a point, I'll come back to answer the question, but we'll probably get into a point where we may be able to, like in the case of HIV, we have phylogenetic trees. These are, scientific methods whereby you are able to trace the origin of a virus. That is, I take virus A, B, C, D. I can now say A, B, C, D are linked genetically to E. And therefore, they are from that same tree. So I can say that this person was the one that gave this virus to this person, to this person. I'm not too sure that we've gotten to the point where a phylogenetic tree has been developed. Maybe it has, I'm not too sure. But now, the reason why we say community transmission is because a lot of times we are unable to track down to somebody who is positive. We cannot link you to somebody. We just tested you in the community and here you are with the virus. Now the implication or the message for you and I is the fact that because it is now in the community, in places where we don't know, where we cannot link to somebody, we have got to be we've got to be more careful than ever before. When I look at the situation, say, in New York, and I recall anytime you are in places like that and you are traveling, you enter buses, or in London buses, you enter buses, you hold rails, you put your hand on seats. All these are potential places where this virus have been dropped. Now in Nigeria, where will be the possible places? You go to the market, even the measuring pan that they are measuring to put there, you don't know what has happened there. The leather they are giving you, you are not sure what has dropped there. So I told my the people in my house, I
I'm
said,
afraid, Dr. Dakum,
we are
I'm afraid we need to go at this point in time, but really interesting getting those perspectives from you. Always a pleasure to have you on. Dr. Dakum is the CEO of Institute of Human Virology in Nigeria. Thank you very much indeed for your time this morning. All right, then, so we will be back in just a moment. Don't go away.